we have a few minutes for questions. So I will take my prerogative as the moderator and ask a question. It relates to collaboration. Certainly one of the best ways for any complex issue that has multiple stakeholders to come to the best conclusion is through collaboration. How do you see information technology playing a role in that extended collaboration really across all the different venues of care?
Anybody or?
Sure, yeah, anybody.
I think it's essential. I think it goes back to the whole cultural issue. People are forced to use technology, and I've actually seen this where practices have been forced to use technology, and a year later they're either not using it or not using it anywhere near the success because the people that put it in did not take the time to work with that group, to have them understand what they were going to be doing, have them have a voice in it, and so forth. I don't know if that's an answer to your question, but it's critical. It may not become as critical later on as doctors are educated through systems where they use these things. But right now, you got a whole bunch of docs. I had one doc when I gave a talk about health reform and similar things. He's a very, very good doc, very highly skilled. He got up at the end of the meeting and said, "How can we stop all this?" So you've got a lot of people in the resistance camp.
I always think I kind of see a three-legged stool. You need all three of them. I think to have a successful implementation, you need to have those health record systems. You have to have that EMR system accessible. I think because it's now patient information, we have to manage the trust of our patients. And therefore, you need to have that privacy compliant piece to make sure that whatever solution you're putting out is complying with HIPAA and the HITECH Act and all the new regulations giving some teeth to protecting privacy. But if you don't have collaboration, if you don't have the ability to know who is on shift today and who I can talk to, who I can send a text message to or a BlackBerry PM to, who I can click a button and call, I think you're missing a huge piece of that pie. And so I really see that collaboration is what really enables it and brings it to life. I think a lot of organizations have spent a lot of money on health records systems in the medical end of it. But if you're not bringing the rest around, then your nurse is spending 2 extra miles walking around because they can't be pulled in. I think a lot of physicians in the US, numbers are coming like 80% of physicians have some form of smartphone. So on one side, we've got leaders that are driving the system that have the technology and can collaborate, but the rest of the system doesn't. And I think that you need to have the whole group working together.
I do see that in our environment, there's tremendous collaboration because people can send information back and forth and get the data so much more quickly and timely, and the follow-up just completes the circle and it makes it much, much more efficient and timely. But the other thing I'll do is I'll challenge, if the culture changes with the technology, everybody uses the system. The oldest people we have using the system today are a couple of neurosurgeons that are in their 80s that refuse to retire, and they're seeing patients on an outpatient basis. We've had physicians that have joined us from Georgetown, approaching 60, that wanted to come to GW because they wanted to have an electronic health record, and they did not want to wait until the other institution actually acquired a paper record. To say that it's only the young physicians that are going to adopt technology, that's not true. One of the most innovative physicians we have from a technology perspective is the head of cardiology, and he is 60-something, and again, he is the one that submitted the grant for heart failure patients using cell phones, as well as moving forward with diabetes. Across the whole culture of the organization, we've really adopted technology to create a changed environment. If I were to say, this is just too expensive, we don't want to do it again, we want to go back to paper records, I'd be fired.
Yeah, I think what you've done, though, is you've created the culture, and you've worked on the culture, and you've seen that as being an important part of it.
Absolutely. mean, when we adopted the system, one of the things that we had was the CEO of Allscripts said, you know, I'd like to be able to show people that we can implement 100 physicians in 30 days. Would you be willing to try it at GW? And I said, of course. So Glenn and I worked out a deal. He allowed us to have more resources than we could have otherwise. And we implemented the system in 30 days. And how did we do that? We said, we're implementing it in 30 days. If there's any discussion that you want to have about this implementation, let's talk about the strategy and how do we accomplish this or how do we accomplish that. Not whether we're going to do it, not when we're going to do it. It was entirely on the implementation of the project plan. And again, we did not take bad systems, which we had plenty of, and automate them. We went through the organization and we said, this is how we're going to transform healthcare in the Department of Medicine, which was the first department that was implemented back in 2003.
Are there other questions? Lee?
So I've been thinking a lot about the evolution of clinical quality measurement. Recently, there's so many programs that are emerging or that have been implemented in recent years, everything from the e-prescribing incentives to PQRI to meaningful use to accountable care to value-based purchasing. I mean, you know, the gamut. And I'm just wondering if you have any comments on that, Dr. Fortuna, from a quality management perspective, Steve, from what it does to your organization, you know, to have to manage these and report on them, what opportunity is presented to you from a revenue perspective, because I think that's an overwhelming element, but it's actually fairly manageable for people. So I'd love your thoughts.
Well, in Michigan, we've had for several years a program where physicians are incentivized by one of the largest payers on the basis of performance, and all of that's tracked very carefully with electronic means and other means. Some of it's actually hand means. They've adapted to it over time, and they've seen it as part of their normal thing to be accountable for these kinds of things, much in the same way that we're trying to move our whole system to be accountable for outcomes and other things. So I think it's possible, and if it's done electronically, it reduces the burden. And I think that's the key thing, because I think that's one of the biggest, strongest cost incentives to physician groups, at least, is that it makes it easier for them to do the reporting that they have to do. And it's a very useful thing in that regard.
Do I have time for one more question?
Yeah, I think he wanted to answer.
You know, are we happy with PQRI and the e-prescribe incentives? When money falls for trees, we're happy to pick it up. And we appreciate it, because we are a not-for-profit organization, and it does help pay for some of the technology. It doesn't necessarily drive our strategy, because I think our strategy is really driven by, you know, academics and quality of care and really fully embracing the electronic health record. You know, ACOs is a whole issue. And I don't think we have enough time here to talk about the problems associated with the draft regulations, which we'll hope to be thrown out with some real regulations coming back.
I have time? Yep. Other questions? Come on, I'm sure this is not a shy group. In that case, that must mean everybody, yes?
I want to ask Dr. Fortuna, just in terms of health IT policy ideas for the folks that are here from the Hill in the room. And you talk about what needs to be done in terms of integrated care models and moving to different delivery models through patient-centered medical home and other ideas. I believe ACO's off the table for the moment. But what could be done in a policy sense to help foster that? You know, does that, you know, obviously does IT have a role?
I think that if there were a way to do exactly what he has done in his institution, and others have done in other institutions, and that is go through the system, not just put computers in on top of the existing systems, but do the process re-engineering, pay attention to the culture, which leads not only to better use initially, but also sustainment. We did a study, a cultural study of a group of 13 practices. And they had gone through lean training, very extensive lean training from the best in the business, a year and a half earlier. None of them were using it because it wasn't made an integral part of their culture. Now, you can't legislate culture, but you sure as heck can say that you have to take some steps using appropriate change management methodologies, using cultural reinforcement methodologies, continuous improvement, and right-sizing and re-engineering the actual processes so that when computerization comes, they flow much easier and can be sustained in that flow, and the people are wanting to use those things. I don't know if that answers your question, but that...
Okay, well, thank you all very much. Is there a break now?
There's going to be. Yes. So, thank you to our panel. We're going to be taking a 10-minute break, but to encourage you to return. Our next panel is on the 112th Congress and Congressional view from Capitol Hill. We have folks from Ways and Means. We have Energy and Commerce. So please come back for that.